Hello, everybody. This is our second attempt at a live stream. We had a request 2 days ago to talk about PPPD. The comment was, I was recently diagnosed with PPPD. I am making great strides in healing with a lot of different vestibular and vision exercises, as well as walking and relaxation. Can you talk about 3PD and also whether traveling, like flying, might affect it? And if so, in what way? And I think this is a really great topic to hit on just because this is something that's rising in diagnosis. And we just had a fantastic presentation at our last virtual live conference with the Vestibular Disorders Association that was given by Janine Holmberg. So if you haven't already watched the conference, head over to www.vestibular.org, look for last year's live conference or virtual conference. And I think it's as easy as paying $20. You get recordings of the whole week of everything that was covered. But Janine Holmberg graced us with her presence and gave the most amazing 3PD lecture that I'm going to take little bits and pieces from to give you some more information on today, because she did a great job of outlining exactly what this is and what the diagnostic criteria is and how we go about treating this as physical therapists. So first of all, PPPD stands for Persistent Postural Perceptual Dizziness, also known as 3PD. It's had other names in the past, like chronic subjective dizziness. This is a persistent, non-vertiginous, so not room-spinning dizziness or unsteadiness that's been lasting for longer than 3 months. It's present most days, and you can feel worse primarily when you're upright and exposed to complex or moving visual stimuli, or even during passive and active head motion. It's usually triggered by a disruption to balance. This is a chronic vestibular syndrome. So this is something that is usually greater than 3 to 6 months. Most of the time, people can experience this for years. It involves the inner ear, which is part of our balance organ. And it's a syndrome. It's a very highly variable presentation with a lot of different things that play into it. And basically giving you the idea that one person from 3PD suffering from 3PD might look different from another person suffering from 3PD. It's not like it looks the same from person to person to person. It's unique for everybody that experiences this. It's not caused specifically by any structural problem. It's more of a maladaptation or a shift that functions within the networks of the brain. The wiring is a little off, and it's actually very, very common. There are some diagnostic criteria. So for all those clinicians out there listening, this is something that we want to listen for in our history. It's a non-spinning dizziness, vertiginous. So we're hearing a lot of rocking, swaying, bobbing, bouncing, brain fog, fullness, heaviness, kind of like what you would hear from a patient recovering from maybe the acute stages of a vestibular dysfunction. There's that brain fog. They just can't quite catch up with things, but they also have this constant sensation of rocking and bobbing that doesn't get better with motion. It's also very vague unsteadiness. So feeling really imbalanced on your feet, feelings of veering without really having any sort of direction preponderance. Like they're not always going to the right. They might lose their balance in all different directions. For duration, it has to be present for over 3 months to meet the diagnostic criteria. As far as timing, this is persistent, prolonged, hours on end, never ceasing. It might wax and wane. It might be present most of the time, almost all the days, and can be aggravated and seem worse some days and better the other days. Some provoking factors of 3PD are complex visual motion. So this is being at the grocery store or in large open spaces with a lot of moving parts, active, passive head motion, and it's typically most severe when you're standing and walking. Onset is sudden. It is typically triggered by a preceding event that has some sort of vestibular component to it, but the symptoms are going to be different than what initially caused this event. As far as being disabling, it can cause a lot of distress, a lot of functional impairment, being able to just utilize your normal activities during your day. And also it's a diagnosis by exclusion. So if there's nothing else in the health history that sounds like this could possibly be, and you're meeting all this diagnostic criteria, 3PD should be something that should be considered. When we're looking at the events that cause or trigger this to happen, 70% is usually from some sort of vestibular or otoneurologic crisis, right? Inner ear infection, neuritis, BPPD, migraine, concussion, some type of fainting event. But also some of this can be due to an onset of a panic attack that triggers similar symptoms. Very, very common. This is about the second most common diagnosis. It's not a psychiatric diagnosis, but highly interactive with anxiety and depression. So this is something that we might see in patient populations that have more anxiety, but it's not necessarily a psychiatric issue. This is a functional neurologic condition. This is something that's happening within the brain that's creating these symptoms that the patient is feeling. Sometimes these patients might have, before we had the diagnostic criteria, might have been written off as malingerers, right? Their presentation didn't quite make sense. They had maladaptive balance strategies to stay on their feet, especially when you challenge them. And it just didn't quite line up with anything that we were seeing in a medical textbook. So this is something that's going to differ from patient to patient, and it's really going to vary. But the good thing from there is that we can kind of take some of these areas of dysfunction, recognize them in our evaluation, and work with the patient to help them feel better. It's definitely a multidisciplinary approach. A lot of education on the patient's part. Sometimes they might need a medication to help them out. So getting to a doctor and they might prescribe something like an SSRI or an SNRI. And then having a combination between cognitive behavioral therapy and a vestibular therapy or physical therapy and exercise has been shown to be really, really effective. As far as the physical therapy component of all of this, we want to try to get things to be re-weighted, right? So we're putting too much emphasis on visual cues. That's where it becomes difficult to navigate out in a big open space. These patients might have a different subjective vertical alignment with their balance. And you can do the vertical alignment test with a little bucket if you go through the bedside evaluation to see if that might be skewed. If that's skewed, then the patient might be over-relying on visual cues in order to navigate their world. So this becomes difficult in large open spaces if you can't align yourself to something vertical. In a small, close room where you've got walls and corners and doorways and molding and framing, this is good. But when you're out and about and things are moving around you and moving in your periphery, that can make it really difficult, disorienting, and actually give people the feeling that they're going to fall over. So we want to re-weight this. We want to distract these perceptions of dizziness and imbalance and try to put focus on what's going on in the body. What type of information are we receiving that's correct? And you can do a lot of this through grounding exercises, right? I use a meditation app. I use Insight, and they have some talks that are body mapping, or even just working on grounding and feeling the surfaces that you're on, feeling that your body is still, working on breathing and calming down that system to try to help calm things and feel what's going on, be more in touch with your body, in tune with what's going on as far as information being sent to the brain. A lot of this can also help with proprioceptive and somatosensory type exercises like Tai Chi, yoga, Pilates, something where you're working on your breathing while feeling how your body is working at the same time. And then also getting into your vestibular exercises. We want to habituate and desensitize some of these motions that are feeling terrible for the patient. So, we do a really, really good job of avoiding the things that make us feel bad. And when we avoid those behaviors for too long, they become foreign to us. So that when we do have to bend over to unload the dishwasher or walk around and do something that feels foreign to us, it feels more symptomatic. So we can actually train the brain to start feeling better during those activities by doing it over and over and over again, which makes vestibular therapy very counterintuitive sometimes, because we're constantly hitting on something that creates a symptom. But if we don't, the body's never going to learn how to reorganize the information coming from that movement that we're doing. So it's not unusual to feel a little worse before you feel better during vestibular therapy. But it should also be noted that vestibular therapy is never no pain, no gain. You always want to never push it too much. You want to kind of keep your symptoms at a manageable level, and then kind of progress forward from there slowly. And just also working on some balance, right? Generalized balance and being on different surfaces and challenging base of support are going to be important to help, move that patient along in the right direction. So we're looking at generalized balance, functional balance. We're looking at desensitization or habituation. And sometimes, depending on the patient, they might need to learn how to habituate or feel better with visual stimuli. So as the patient moves along and you notice this progress, you're going to end up working with them on some of these exercises with some visual conflict as well, as long as they can tolerate. Ideally, we want to get them back to being able to shop in a grocery store and turn their head side to side, or walk down a busy sidewalk, or get down into a metro station, have things moving in the periphery without making them feel like they're going to fall over. There's so much that we have to do where we interact with a bigger environment every single day that we have to get patients back to doing. And sometimes it's a snail's pace getting there. Sometimes they start to notice improvement, pretty quickly, especially with that multidisciplinary approach of potentially trying medications and working with a cognitive behavioral therapist. But the great thing about the position of the physical therapist in all of this is that you can kind of be the person that holds their hand and walks them through this. You're going to see them more often than the other providers that they might be seeing for care. You can reassure them that this is normal, this is okay, there's not anything specifically horrifically wrong with you, and this is going to get better. And sometimes peeling away that anxiety, helping them learn to ground and do some relaxation techniques while also getting them through some functional activities with balance is enough to point them in the right direction and get them a lot of relief. So I hope that was at least a little bit helpful. Again, there's a full talk on this with Janine Holmberg, who's absolutely amazing. We were so lucky to get her for a speaker for our first virtual vestibular conference with Vita. Please go on Vita and check that out if you haven't already purchased the week. The donation in order to get to the recording is extremely helpful for the vestibular community. It allows us to do more fun events like having Janine come on and talk about 3PD. If you have any questions, leave them in the comments. Any other requests, put them up there, and we'll try to get to topics as much as we can. All right. I hope you guys have a good day, and until the next live stream.